Good morning, everyone. I have Dr. Ted Johnson with me from Wheat Ridge, Colorado. And Ted and I, we go way back, don't we, Ted?
Oh, we do. Yeah, back to the early 2000s, I'd say.
Yes, that's right. We've been friends, too, forever. I really love your family and your team, and I love the area where you practice, and you're just a great dentist. And let me tell you a little bit about Dr. Ted Johnson. He's in Wheat Ridge, Colorado, as I mentioned. And you graduated from Washington University in St. Louis, didn't you?
That's correct. Yeah, back in 1986.
Oh, I wondered if you were going to tell the year or not.
Yep, that's all right.
Okay, great.
Proud of the years.
When you get where we are, you kind of are proud of those years.
We've earned that, yeah, haven't we?
Yes, we have. And you've been a clinical instructor out there in Colorado, haven't you?
Right, I have at the University of Colorado briefly. Yes, we taught occlusion there back for Dean Landesman.
Oh, yeah, great. And that's more of what we're going to talk about today. We're going to talk about occlusion and IPSO, a program that Dr. Johnson teaches. So we're going to learn more about that. And also, man, for over 10 years, you've been in Denver's 5280 Top Dentist magazine, right?
I have been. I've been very fortunate with that. I have a great team pushing me along, though.
Yes, you do. And then it was was it 2 years ago that you were inducted into the American College of Dentists?
That's correct. Yes, I'm very fortunate to be included with a great bunch of people. Yes.
Wonderful. And I'll tell you a little bit about their practice. They're cross-trained. They're what I call the seamless team. In other words, everyone knows how to do everything pretty much. Sometimes clinical cross-train, admin cross-train, except for hygiene maybe and doctor. But you have an amazing team. They're highly trained, highly skilled, and work well together in doing all of the unique things that you do. I believe your practice it's kind of a hybrid, I call it. You have a general dentist practice, but you also have kind of a boutique or you're almost a specialist in the sense of the word of what you do with occlusion. So
that's correct, yes.
Very interesting. So why don't you tell us a little bit about how you got into dentistry? I mean, why did you choose that career?
Well, that's kind of a long story, but when I was I started out wanting to be a pro baseball player.
Oh.
So I went to college basically to play baseball and found out pretty quickly that I wasn't any longer the big fish in the little pond. I was just the opposite. I was the little fish in the big pond suddenly. And so I had to figure something out. And my dad had always wanted to be a dentist. And he became a petroleum geologist later on. But he kind of guided me into that because he'd always liked that. He'd worked in a dental lab when he was a child or as a teen, I guess. And so he steered me into that. I went to a Boy Scouts Explorer program and watched that and became interested. And then later on, before I got into dental school, my dentist at the time, Dick Shaver, was a general dentist that also practiced homebound dentistry. Excuse me. And so I used to go around with him in the summer times to the nursing homes, and I got to see the people that we got to work with and helped him, and I really fell in love with it. And so that's what I did for the first 3 years out of my practice, or after I got out of dental school in my practice, before I joined and opened my own practice. So, and then I continued to do that for a long time, and we still see a lot of seniors that are now mobile enough that we can bring them into my office and do things under ideal conditions instead of in a dark bedroom,
Yeah.
Forget something, when you're an instrument or some restorative material or something like that. So it's a better way to go, but we still hold our seniors dear in our heart.
Yes, that's special. I know you have a lot of senior patients, and they just love you to death.
Yeah, thank you.
So how did you get into occlusion?
When I was out of dental school, I was a good student, and I did everything by the book because I thought that was how it was supposed to be. Mm-hmm. And, as my first 10 years of practice before I got into the occlusion realm, I see patients, and two of them stick out in my mind right now. One was a lady that had been to one of the burger franchises. I won't name them, but she said she bit into a piece of bone and broke a tooth, which is the second molar, tooth number 30, 31.
Ouch.
And so I was repairing the tooth and preparing it for a crown, and I reduced the occlusal surface of the tooth and was getting ready to put a temporary crown onto that tooth. And lo and behold, the teeth were touching again. You know, the prep tooth was touching the opposing number 2, and I had no idea what had gone on. And I had to re-prep it again. I was worried about getting into a root canal situation, and I never really understood that until I went through the occlusal course. And then I had another patient that was a pain patient, and you know, she had headaches, neck aches, migraines, and she was just in terrible pain really all of the time. And I sent her to oral surgeons and endodontists and orthodontists, and I thought surely she knows or they know what's going on and know how to take care of her. And she never did find out before she left my practice. She was upset and just in a lot of pain, but we never did find the cause of her problem at the time. Later on, I found out it was myofascial pain, and I believe that if I'd have known what I knew after going through the occlusal training, that I could have taken really good care of her and helped her out a lot. So those two people stick out in my mind. And so we took the course after I was, it was called Niles Gachet and Associates, the NGA program, back in 1996. So I'd been out of practice, 10 years at that point. And it's participative as it still is. And from the very beginning, I started to incorporate the principles into my practice, and immediately I had success with people with the similar reasons that lady that had all the pain had. So I was taking pain patients that were miserable, taking time off of work because they had migraines, and immediately with my first patients during the training, we had immediate success. And one of my first two patients is still with me 22 years later.
Wow.
And has never had a migraine or a headache since then. When she was having daily migraines, they had a little room for this lady. She was a high-level bank executive, and she had a little room that she'd go in and sleep off her migraine every single day. And since we first took care of this patient in my NGA training, which is now called IPSO, she's never had a migraine since that time.
Oh my goodness! Wow, what a success story! That's amazing.
Yeah, it's huge.
Gracious. So what is IPSO, and how did it came out of Niles Gachet? And it stands for International Partnership for the Study of Occlusion, right?
That's exactly right.
Okay.
Well, Niles Gachet had a number of instructors that began to disagree with them on some of the teaching principles.
Imagine that.
And yeah, sometimes that happens. And so they broke away and formed IPSO, the International Partnership for the Study of Occlusion. So they were basically all of his lieutenants at that point in time, and there were 5 of them. And so they formed that, and the senior guys that taught me have retired. Some of them have had some health concerns. One passed away, and the program was going to be just shut down. But Dan Sellner and Ken Peters, who were dentists in the Denver area that took the same courses at the same time that I did, stepped up and we thought so highly of the program, and we knew how much of a difference it had made in our lives and in our practices, that we wanted to keep it going and continue to teach this to future dentists as long as we could, and then hopefully we can pass that on to somebody else to continue teaching it, because it's made such a tremendous difference in our practices.
Wow, absolutely. So how long have you been involved with IPSO?
I started in 1996 taking the courses, again, the NGA, but then in 2009, I believe, is when we took it over and started teaching it. So we've been in 13 years.
Okay.
And we kind of dipped our toes in the water with the senior instructors and learned what they were doing and had things passed on to us. We were very fortunate in that regard because we were the new future for that program, and we've kept it going since then.
That's amazing. That's awesome that you've been able to do that. And I've been to a couple of your meetings where you've talked about the principles, and Dr. Johnson's been a guest at our Mastermind Leadership course, and he's led breakout sessions, and I've seen some of the things you do. You'll actually work with a person, you'll call them up front, and you walk through where their jaw pain is, and it's amazing what you're doing. So I know there's lots of schools of thought, but this is really where you've landed, and you're passionate about it. And so,
absolutely, yes.
Can you tell us a little bit about what you teach, and is there a way to summarize that? Or
well, I can tell you briefly about the program, the IPSO
okay.
program.
Okay.
We start out with a 3-day didactic and hands-on program,
Uh-huh.
and the student will take information back that they can incorporate into their practice, Monday morning.
Mm-hmm.
So the next course that we have is going to be on August 24th, 25th, and 26th here in Denver,
Mm-hmm.
and it's a 3-day program, as I said. It's called Occlusion in Everyday Dentistry, and basically we talk about anatomy, physiology, history of occlusal treatment, criteria of optimum occlusion, occlusal equilibration, centric relation appliances and anterior repositioning appliance, instrumentation, clinical application, what do we do, how and why do we do it, and then we talk about how to incorporate that into our practice or their practice as well.
All right. That's a 3-day. Who do you recommend come to that? Would a doctor who's only been in practice a few years come to this, or more experienced dentist, or what?
Yes. How's that?
Both.
How's
okay.
That answer?
Okay. Well, that answers that
You
question.
get the whole gamut, and that's exactly why I said yes, because it's for the new dentist. I was out 10 years, and sometimes that's kind of nice to have a little bit of a practice under your belt. But we've certainly got brand new dentists right out of school that really embrace the principles that we're teaching.
Mm-hmm.
And we've had dentists that have been in practice 30 years that come in to see us.
Yeah. Okay.
We also work with all the specialties because we feel like a knowledge of occlusion is foundational and fundamental to all specialties, except for maybe oral pathology. That's the only time that it might not have an application. But all the specialties certainly can benefit.
Now, you've even gone outside of dentistry with this. I know you have with neurologists and ENTs. Tell more about that.
We've ENTs. There's a lot of airway issues that are coming up right now.
Yes.
I mean, they've always been there, but it's a hot new field.
Right.
And I used to say that I thought occlusion was the holy grail of dentistry. And I don't believe that anymore. I think probably even more foundational or causative for the TMJ and occlusal issues may be that there's an airway component. And so we're incorporating airway into our teaching as well because we feel like it has a strong cause as well for people to have TMJ or occlusal issues.
It really
starting
does.
Starting out with our program, it's foundational. It's something that every dentist can use every day, and every specialist can use every day. It doesn't have to be the airway or the TMJ type of a practice.
How do you see airway affecting TMD? I know you showed some pictures at the retreat of a patient. I believe he was tongue thrusting or something.
There's tongue thrusting, head forward issues. Teeth can be splayed due to tongue thrusting. If people are struggling to breathe at night, they tend to grind or clench their teeth, which breaks teeth. It moves teeth. It can cause tremendous headache, neck ache, facial pain, back fractions, perio disease. A lot of endodontists have problems or need to have a knowledge, is a better way to put it, of whether it's an occlusal issue or is it really a pulpal issue that needs to be taken care of and treated. And they're two separate. You can do a root canal on a tooth, but the tooth may still hurt afterwards. Then it goes to extractions, and then certainly leads to bigger types of dentistry and maybe unnecessary types of dentistry.
Right. Absolutely. And I've seen that, and I've even I mean, in my own experience, I was having some issues and went to an ENT. My medical doctor told me to go to the ENT, check out my ear, and that wasn't my problem. So I wanted to bring that up about you talking to ENTs, because you're getting referrals from ENT now when they're not finding a problem, and you're thinking, well, maybe they really need to go see the dentist.
That's exactly right.
Mm-hmm.
We're getting referrals from both ENTs and neurologists or neurosurgeons, whoever the patient gets to see first, and so they know our name, Johnson Dental here in Wheat Ridge, and we're able to help them in the vast majority of cases. So it's been nice that they've been able to be checked out by their our medical partners. And
yes.
They've diagnosed that they can't find anything wrong, and so then when they come to see us, then we have a really good foundation or background to go off of, so that we can begin to help them. And it's amazing how and gratifying how effective this is for our patients.
That's awesome. You've really created what I call a wellness alliance.
Right, I agree with that.
Where you're working with all types of medicine and dentists, the dental specialties and everything to help the patient, because the symptoms can be, the headache or the ear pain. It can be misleading as to what the problem is, and most patients treat the symptom and they don't get to the root of it.
Right. People are taking handfuls of ibuprofen, which is really horrible for their stomachs.
Yes.
It's debilitative. So, yes.
Absolutely.
Yes, thank you. Go ahead. Sorry.
So, no, and the airway, like you mentioned, I want to come back to that too, because that is a huge deal right now. There's much more awareness about this. I mean, we're even seeing this in kids where they're misdiagnosing ADHD because it's really an airway issue and they're not sleeping well.
Exactly. And to that point, there's a huge growth spurt in age 4 to 7 year olds in a person's brain.
Huh.
And if they're not getting enough oxygen, it is leading to ADD, ADHD issues. We've seen it in adults as well, where once they get enough oxygen, especially when they sleep, the symptoms decline. So, and so with this brain or lack of brain development, proper brain development, there's people that, for no other apparent reason, have become mentally slower than they could or should be. And so we're trying to be preventive because many people, and I probably would say most, see the dentist twice a year at a minimum, and they only go to see their physician only if they absolutely need to. So it's become incumbent upon the dentist to be the diagnosticator, I guess I'll call it that, looking for these kind of issues so that they can be steered properly to the proper medical professionals for proper treatment.
That is so true, and I think in maybe Illinois, Chicago, somewhere, there is already a beta test that's happening of having nurse practitioners in dental offices to do blood panel, and they can prescribe all of that, and their medical insurance, I guess, pays for it, but there's more merging of medical and dental as far as recognizing something. Dentists just somehow the mouth got separated from the body back in the 50s or somewhere, and
isn't that crazy? Yes, it's just not really like that.
We want to put it back where it belongs. And you're doing some airway mapping. Tell us about what you're doing with that.
Well, what we do is for people that we suspect, with a bunch of questions, and let me take a step back and say it's amazing what you'll find out if you start asking the proper questions.
Oh.
And so we have a list of questions that have to do with sleep and sleep disorders, and have our patients fill out this before we start to take care of their occlusal symptoms. And so what we will do is if it looks like people are having some difficulties, we'll send them for some three-dimensional radiographs, imaging, and we use a company here in Denver called DDI, or beam readers, and then we have the information sent to oral maxillofacial radiologist to diagnose this for us, and it comes back. The information comes back in a form from the radiologist in a nice letter, diagnosing what is or isn't right with their airway, and it could be something about their sinuses, their turbinates, whether they have a deviated septum, the dimension of their airway into their lungs from the back of their throat.
Mm-hmm.
A long palate diminishes the airway diameter, and and they also talked about what their TMJs look like at the same time, whether they have sclerosis or flattening, where the disc is, the articular disc,
Mm-hmm.
in relation to the fossa and the condylar heads.
Mm-hmm.
So we get all kinds of proper information, and what this allows us to do is to make a proper diagnosis, as I mentioned earlier, and or referral to an ENT or a neurologist or whoever needs to help with this, or possibly an oral surgeon and orthodontist.
Right.
And so,
wow.
bottom line for this is we feel like we're making a proper diagnosis instead of misdiagnosing and mistreating a patient, as we might do if we didn't have all the information in front of us.
And that is so huge these days when doctors are in a hurry. They're having to see more patients because of all the insurance plans, and they would rather write a script.
Right.
They don't, let's see if that fixes it. If it doesn't go away, then you have to go through a battery of tests, and you don't always get to what's really going on.
I agree with that.
Mm-hmm.
And what does a patient get, 7 minutes or something like that with their medical doctor?
Yeah, it's actually less now. I think it's 5.
Oh my gosh.
Yeah. Mm-hmm. So I think we're doing a great service for the patient, for their overall well-being when we're looking at these things. So real quick, when you see a patient, let's say you've got a patient that comes in with popping and clicking, and I know you really, that's where your passion is. So where do you start with them? I'm sure you probably start with a questionnaire.
Exactly, right.
And then
do an interview. Yep.
Mm-hmm. Okay.
So have them do an interview with us, and we ask them a number of questions about what their symptoms are,
Mm-hmm.
how long has it been happening, their problem been a problem, when does it happen, what are the symptoms, headaches, neck aches, facial pain, clicking, popping,
Mm-hmm.
They can't get their teeth together perhaps, TMJ pain, TMJ, crepitus, sounds like that, and then we'll have them fill out that oral questionnaire that I talked about briefly earlier,
Mm-hmm.
a number of questions about their sleep habits, an Epworth score to diagnose how well they are able to stay awake during the day.
Mm-hmm.
And we combine all this information with the next thing we'll do is a extensive occlusal examination. So we check muscles, palpate muscles, try to find out where the myalgia or the muscle pain is, how symptomatic is it,
Mm-hmm.
what level is it. We'll measure maximum openings, use a stethoscope to find out where the click and pop is in the opening stroke, and then try to diagnose whether I think I can help a patient or not, because it depends ultimately on how much damage is in the jaw joints.
Right. That's a good point. Mm-hmm.
Exactly.
And it's very thorough. And, a lot of people will do a TMJ exam in their comp exam, but I think you take it a lot further than that.
Well, we try to just go beyond being able to diagnose it, which is a huge first step,
Mm-hmm.
but then we take it to the next step of how we can help a patient.
Mm-hmm.
And there's so much of this as a need amongst patients in the public, and it doesn't matter whether you're in Washington or Florida or Missouri or Colorado. It's really all over the world.
Mm-hmm.
And so we feel very fortunate again that we were able to have the knowledge to take care of these people, and it's in every practice. And
It is. Mm-hmm.
Dr. Bassett, my mentor, used to say that there's a whole other practice living within your file cabinet.
Oh, yeah.
We don't necessarily have file cabinets like we used to.
Yeah.
Since we've gotten away, a number of us have gotten away from that. But the point is
Mm-hmm.
there's a whole other practice within your practice.
And that's exactly what you've created. You've done that. So, I know you've even taken this IPSO course to England.
Right.
Just fantastic. And, are you finding that Europe, are they getting this kind of information? Is anybody else teaching this over there?
There may be another camp or two that go over there. I don't know how active they are. We go every year, and we work with the British Society for Occlusal Studies, BSOS.
Yeah.
And that's the international portion of our group.
Okay.
We've been doing this. Our group has been doing this since the early 70s, and so we have a really a big niche working with them. And when we're working with the British, we get people from all over the European Union. I mean, we've had the Czech Republic, Portugal, Africa, France, Ireland, Scotland. So we're getting a really huge number of dentists that come to our programs over there.
They're hungry for it too.
They are.
I mean,
Yep. And they grasp it real quickly.
That's great. And the thing I really love about what you've done with this in your practice, back to your practice, is you're getting referrals, not just from other patients, but from other doctors. And when a patient is told by a doctor, I want you to go see this other doctor, they're more likely to come than just somebody at a soccer game saying, hey, I've got a great dentist, do you want to go see him? They still do. I mean, but when another doctor refers them, I think it just has more clout, more power, and they're more likely to go. Is that your experience?
Oh, I absolutely believe that. And we're receiving referrals from dentists and physicians that I've never heard of.
Wow.
And so I think that's a testament to our effectiveness. That word is getting around amongst dentists that we've worked with or physicians that we've worked with, and word is beginning to spread. And so we're getting, I get patients from Southern Colorado, an 8-hour, 9-hour drive away from here now because we've had a couple of patients that have worked with the same dentist in Southern Colorado. And so word is spreading down there, and we're getting people driving all the way up here to see us.
Wow, that's amazing.
Exactly. And we had a lady from Oklahoma here last year too.
Oh, goodness.
Couldn't find who she wanted to see, and we were able to help her as well. So
you're famous. You're famous.
Well, at least in my own mind. How's that? That may be the extent of it. So. Well,
and that's the other thing. You can create a niche in your practice for this because not every dentist really wants to deal with it.
Right.
You have a passion for it, and I believe you need a passion to deal with it because there's a lot of visits and splint checks and things like that. But I think, coming to the course can help you learn more about it and even learn more on how to refer it and how to recognize it.
Absolutely. Yeah.
So tell us again when the course, August, you said a 3-day?
The 3-day introductory course, which is mandatory for the other levels of the course later on, is on August 24th, 25th, and 26th here in Denver.
That's a Friday, Saturday, Sunday, isn't it?
That's exactly right. It's 3 days. It's kind of like drinking from a fire hose, but what's really nice is that all of us are committed to the success of each of our participants, and we're available for phone calls or emails or whatever it takes to make people, the dentists that have participated with us, to be successful in treating their patients.
Awesome.
Yes.
Okay, so how would they get in touch with you?
Well, there's a couple ways. One is you can call my office at just my office number is 303 area code 422-8748. Or our website is ipsoseminars.com or .org. We have both.
Oh, okay.
So IPSO seminars, all one type of a word, and it talks about our courses, and what our program is.
Okay. All right. That's wonderful. Well, thank you so much for taking time to share with us today. I really believe in what you're doing, and I wanted you to share with everybody and record this. I know you've come to our retreats, and there's a lot more dentists out there who have not heard about what you're doing and want to get the word out. I think it's great. Just being a TMJ sufferer myself, and going for so long without a correct diagnosis, I think it's very frustrating as a patient when doctors start looking at you like you're crazy, and you're making it up, you know.
Exactly.
So it's a wonderful service, and you do an excellent job with it. Your course is amazing, and I've met the other doctors in the course, and they're amazing as well. So I wanted to really help you get the word out about IPSO, and I hope that several of you listening today will look into the course and make it a trip to Colorado in August. It will be beautiful, beautiful part of the country. I love going out there, and you'll learn.
It's a great time to be here too, that time of year. So yes, make it a little vacation.
Awesome. That's right. Okay, well, thank you, Dr. Ted Johnson. It was great to have you on the call, and I look forward to talking with you again soon.
Thank you, Paula. I sure appreciate the opportunity to talk with you and to work with you this many years. So
you're welcome.
Thanks very much.
It's a pleasure. All righty. Bye, everyone.
Bye-bye.